Hadfield with Legends Health, Wellness, and Performance, and I'm super excited about our guest today. I did a bunch of different reviews on the website on her. Her name is Victoria Sutcher. She's a naturopathic medical doctor. And the reviews came back as I just had surgery. One of them came back as I just had surgery, and after going to a variety of different physicians, this was the physician that was able to help me with my chronic disease. Another one of them came back and said, very knowledgeable, very thorough, and I can't imagine a doctor not wanting that as a review. And another one came came back as, kind and passionate and really cares about her patients. So welcome, Dr.
Thank you.
Victoria Sutcher.
Thank you for having me.
Yeah. So my whole mission with Legends Health is so that people actually take charge of their health, and they're coming to you. They're coming to you, and typically they're out of desperation, right? Because they've been to a variety of different physicians, and they haven't been able to find the answers. Where do you usually begin? Where do you start?
Well, typically it's an intake. So every patient is different, every person is unique, and every disease process is unique. And so the first line of defense is basically figuring out what is going on, getting an accurate diagnosis, and then finding out about the patient. I mean, some patients, they have a really stressful life. Well, maybe they need to de-stress, or maybe they need to switch out some of what they're doing lifestyle-wise to get them to a point where they can actually heal. Taking away some of the roadblocks that they might have, so to speak, in their diet or in their lifestyle.
Let's talk about diet, because I know that's such a big aspect of what you do, and I know you have a health coach that kind of helps patients with their diet. Where is there a one diet kind of fits all approach, or is there a different diet depending on the diagnosis?
So diet, and I laugh because there is no one diet.
Okay,
it's whatever works for you. And so I learned in med school, in med school they were very much vegetarian, vegan. Everybody needed to be vegetarian and vegan for health reasons. I'm one of those people that when I go become a vegan or a vegetarian, I become a complete bitch. My fatigue gets worse, my endocrine system completely crashes, and my ability to sleep or anything else is gone. And my filter goes. So I start saying things that maybe I shouldn't be saying. So I need animal products in my diet. Otherwise I don't do well. Well,
is that because of the methyl B12? Is that
no,
what it
that
was?
is just because I have some endocrine issues that if I don't monitor my diet well, then my testosterone goes way too high and my inflammation goes out of control. Well, taking a little bit of animal products every day lowers that inflammation. So I'm not as bitchy, I'm not as fatigued, and I can sleep through the night.
So a lot of your vegan, because I have had a couple vegans on the podcast, and they would tell you that meat is inflammatory.
No.
So what do you say? How do you
So
counteract that?
again, it goes back to your own genetic makeup and your own genetic you. So every person. Saying that everybody's going to do well on a ketogenic diet, or saying everybody's going to do well on a paleo or Atkins diet. No, it's not that cut and dry. You have to customize what's best for your metabolism, what works for you as an individual. So I have patients who, they don't do well on a low carb diet. They have to be on 60% carbs. Well, everything in med school told me that's insane. You shouldn't be on a high carb diet to feel better. I have patients where they have to be on higher carbs to function. So they're not as tired, their brain's functioning better, their brain just works better on the high carbs. I have other patients that are better. Majority of people run better on a high fat diet for cognitive. Not always, but many times.
So how does a person find that out? Because I know there's nutrigenomics
Trial and
tests. I know
error.
there's food sensitivities tests that people are doing, and they're trying to this food is inflammatory. So is that with your help? Like, how are you guiding them to find out what's right for them?
All of the above.
Okay.
So nutrigenomics testing is a great way to start. I usually put everybody on a Mediterranean diet to start with. So just get so going to a whole foods diet, making sure you're eating foods that are high in fiber and more nutrient dense. 9 times out of 10, most people are going to feel better on that.
Yeah.
And most people who go to a vegetarian diet, they're going to feel better just because they're taking out the processed foods. So when you say, oh, I went vegetarian and I felt great, yeah, but in 6 months' time, you're going to be becoming nutrient deficient because there's a lot of foods and nutrients and micronutrients that you need that you can only get from animal products. So are you really, if you're supplementing, you can do a vegan diet, but it's not the healthiest diet.
So let's talk about
having fish and chicken and some poultry. Vegans can do really well maintaining the vegan lifestyle.
Yeah.
But they usually have to add in fish and some poultry.
I know this practice is really big with supplementations and quality supplementations, because because cost becomes an issue. It becomes such a big issue with supplementation. How do you go about deciphering what supplementation and the product or the base of the company, because there's so many different types of supplementations out there?
So I tend to only use professional lines. So I prefer professional brands that are they hold themselves to a standard of, I'm a pharmaceutical company. So there are a lot of professional lines that they do all the testing, making sure that what they say is in there is in there. They do their QC, they're constantly checking their benchmarks and making sure that their quality of the nutrients that they're putting into their products are working, meaning that they're breaking down, you can actually assimilate them, and they're getting into the bloodstream. Okay? So those kinds of quality of products, those are the ones that I recommend. Now, I have a lot of patients that I give them a wide variety to choose from, because again, and if patients are going to get a generic over the counter, I usually say, okay, well, the dosing that I'm giving you is a pharmaceutical grade. So typically if you're doing a over the counter, you're going to have to double to triple that dose to even get the amounts across on the professional brands. So it's actually going to save them more money if they take a professional brand versus a generic, because they're getting a better quality product for less amount that they're having to take.
So many people would say, I even face this myself, so many people would say, I don't want to take the supplements, I'm just going to eat healthy, right? I don't need the supplements if I'm eating healthy. How do you respond to that?
And I would say, well, there's 2 problems with that. One is that if you're eating, majority of we're not cycling our crops like we used to. And we're not infusing the dirt with the manure and the dead nutrient, plant matter and everything else that we used to fertilize with. We're now using synthetic fertilizers, which are destroying the nutrients in the land. And so when you actually look at the amount of nutrient density to the fruits and vegetables that we have now compared to even 15 years ago, it's nearly cut in half. So when you look at nutrient density, basic, just from the food quality standard, it's just at what we're getting at now. Now, to get from a disease state to a more healthy state, not supplementing is really, really difficult. If and you just want to enhance your health, you might be able to do it with diet. But if you're in a disease state, there's no way, because you're not going to be able to get all the nutrients you need to adequately get you back to a state of health on the food sources that we have right now.
So let's talk about the controversy between pharmaceuticals,
Mhm.
and you know, because there's a lot of miseducation, I should say,
Mhm.
about naturopathic physicians, and you know that they're a little weird because they only use supplements,
Mhm.
versus, you know, these pharmaceuticals have all these studies and
Mhm.
they're behind and they're FDA approved, and
Mhm.
supplements are not. And so how do you talk to your patients about that?
My patients, because I prescribe medications. I have a lot of colleagues that will not prescribe medications, which that's a choice on a doctor's side not to prescribe pharmacological drugs or even nutraceuticals. I have some colleagues that don't even use nutrients. They just use diet and hydrotherapy and therapies, and de-stressing and massage therapy and things like that. A lot of what I do is still clinically backed. So, not clinically backed, what's the word that we always use?
Evidence-based.
Evidence-based, thank you. We have evidence-based medicine. Everything I do is evidence-based. Everything I do. So when I tell somebody to take high-dose vitamin C, there is mountains of research backing that up. In fact, most of our pharmaceuticals, we have maybe 1 or 2 studies backing up what we're doing with those, and it was done and paid for by the pharmaceutical company. So when you really start looking at the research, sometimes it can be skewed because a lot of research data does get to be skewed, or it's just barely above placebo. And when you're talking a effect clinically, I wanted a statistically significant increase above placebo at best. Yeah. And most pharmaceutical drugs are barely above statistically significant effect from placebo, or not even close to that. So when you start looking at the actual studies, a lot of times they're not actually reproducible, nor are they actually valid studies. So when you actually start, it's not as evidence-based as we think it is. Now, the problem with studying a lot of the alternative therapies is that there's no way to do a double-blinded placebo-controlled study.
And that's science standard.
Yeah. That is a science standard. So when you're talking, okay, if I was a researcher and I was trying to figure out the benefits of cryotherapy, and I wanted to do a double-blind placebo-controlled study on that, how do I fake cold therapy on a patient? It's a little difficult. Yeah. So it's difficult to have, your placebo group has to be you don't give it to them. So that's not double-blind. So we have to be open in science, basically, of designing new types of studies that include a broader range. It can't just be double-blind placebo. That can't be our gold standard. We did that to try and take the practitioner out of the study, so that we don't know if you're getting the drug or not getting the drug. Yeah. We tried to make it blind so that we couldn't influence the state of the trial based on our biases, which, okay, I would grant that's placebo, but that's still placebo. Even if a practitioner is trying to give some type of encouragement to a patient, oh, you're taking the medication, this should be, you should have more of a response to this, you're still not going to get any better than placebo. So the placebo effect really does filter that out. And so I think we need to kind of re-examine how we do trials so that it is more inclusive to being able to be more accurate. Really.
That's so interesting that you said that, because I just was talking to a pharmacist who sits on the National Treasurer of Cannabis Pharmacy, actually. And he was talking about cannabis, and he was saying, look, he's like, we know of 144 different cannabinoids, and he's like, science is really good at studying one molecule. Yeah. He's like, but everything gets really hazy. He's like, we maybe do okay at 2 to 3 molecules. He's like, but when you're studying 90, 100 molecules, we don't know how to study it. We have, science doesn't have no.
Cannabis is a great example because when you're talking an herb, okay, most of medicines are derived from nature. So take digoxin from digitalis. We take one constituent out of that herb that we think is the active ingredient, and we concentrate it and make it into a drug. The digitalis plant, there are multiple active ingredients in that plant. Same with cannabis. You have, in every herb, you have multiple ingredients in there that we have no clue as to what they're doing. But there's a synergistic effect. So when you take the whole herb, you get a much cleaner effect. You don't get the side effects that you do when you concentrate the active ingredient, so to speak, and put that into a drug. You get a lot of side effects from it. But if you take the plant or the herb, you don't get as many side effects.
So that's interesting, and I want people to understand that that's a difference when we say in science, when we say an isolate, we've isolated out one compound. It just typically means one compound, and then when we're talking about a plant, most plants have that synergistic effect that most practitioners really don't know how that works.
Because we don't.
Yeah. Okay. And do they in medical school, do they dive into that in naturopathic school?
We dive into some of that.
Okay.
So it's still scratched the surface because we still don't understand the complexities of a plant. I mean, from the energetics of the herb, we talk about, to the actual what we know is the active ingredients. But even when you extract the plant, how you extract it and how you. So a dried plant is going to act differently from a tea. So if you infuse the fresh herb ingredient versus the dried, or you make it into a tincture, you're changing the effect of the herb. The herb that does that that illustrates that the best would be ginger root. So dried ginger root has a completely different effect than fresh ginger. And the tincture also has a different effect than either of those two. So fresh ginger is going to be more antiemetic, so anti-nausea. It's going to settle the bowel. It's a good carminative. It really helps to strengthen the bowel and digestive force. Dried ginger is actually better as an anti-inflammatory.
Oh.
Fresh ginger doesn't have the anti-inflammatory effects to it, but dried does. It also is more, the tincture is more for helping blood flow and blood movement, especially in the upper respiratory tract. So cold and flus are going to respond a lot quicker if you're taking ginger tincture or ginger tea, because you're going to get that blood moving effect from it.
That's that's fascinating, because I've studied a little bit about ginger. I've tried to study a little bit about every kind of plant, because my journey is I was in pharmaceutical research. I helped put 15 different drugs on the market, and that was my space until I found out about functional medicine and found out about naturopathic medicine.
Right.
That was really because of my own personal journey that led me there. But and when you go to the internet, you're just reading, the benefits of ginger, the benefits of turmeric.
Yeah.
And, you have to dive down deep to just say what you just said. That's amazing.
But to understand that, that's the level of difference between a doctor and learning on the web, or an herbalist. An herbalist is going to understand that to a degree. But again, a doctor is going to take that to the nth degree, because you have to know what interacts with that herb, what drugs interact with that herb, what herbs may not do well in combination with that herb, or even would this affect Coumadin? Would this affect your any of your meds that you're taking for the bowel? All of those things have to be considered when you're choosing an herb.
Yeah. Okay, so now let's transition a little bit to acute medicine versus chronic conditions, and where your expertise lies and what your thought is between the two of them.
Okay. So acute medicine, we do really good conventional care. So if you wanted to say conventional care was allopathic, MD, DO, that's allopathic care.
Okay.
they do very well acutely. So if I'm in a car accident, I want you to take me to the hospital. Okay? I need to have my bones reset. I need to have some imaging done, make sure I don't have any internal surgery. I need surgery to stop a gut bleed or something like that. That's acute care. However, when it goes into chronic, allopathic and osteopathic medicine doesn't do all that great with chronic care. So when you're talking diabetics, when you're talking an autoimmune condition, when you're talking a persisting infection, we don't do well acutely with acute care. Talking allopathic models versus naturopathic models. So an allopath, the way that they're trained and the way that so their philosophy of medicine, basically. So it's a philosophy of medicine. So allopathic care is we have a condition or a disease state that we need to eradicate. Okay? So we immediately take it, remove it, and you'll be back to care.
Yeah.
So if you have a strep infection, I'm going to give you an antibiotic and it's going to clear it up and you'll be better. Okay? You have a broken bone, I'm going to set it and it'll heal. Okay? That's allopathic care. When you're talking a naturopathic care, or well, let's go osteopath. So osteopath, they're kind of very similar to allopaths. What they're thinking of is more structure. So they're looking at your structure according to your health. So if your structure is out of alignment, so if your spine is out, if you've got your carriage off by a couple of degrees, if your liver is rotated a little bit off, you're going to not function as well. So if we put your structure back into alignment, you'll do better, and allopathic care can actually get you back to health. Okay?
Okay.
Now naturopathic care, we base our philosophy on a couple of credences. So first is that there's value in nature, that nature knows how to fix you and to cure you, and that we have to vitalize your own natural innate healing abilities to get better. So we have to try and stimulate your own nervous system and endocrine system and circulation to get the nutrients wherever we need to get them so that you can start to heal. We also look for tolecausin, which is basically treat the problem. So instead of looking at your symptoms, which acute symptoms, that makes sense. I broke my bone, that's an acute symptom. But if somebody comes in with fatigue, I'm just not going to give you Adderall to help make you feel more up and go, or caffeine.
Yeah.
Here you go, take some caffeine pills. That's a symptom of a problem. Fibromyalgia is not a disease, it's a symptom of a problem. So when you find the actual problem, you fix the problem, the symptoms go away.
So I want to help make sure that this is really clear, because chronic fatigue, fibromyalgia, right?
Right.
There could be different causes behind that. Like
Multiple.
I could have
Multiple.
fatigue because I overexercise and I overtrain.
Correct.
Or I could have fatigue because I live a high stress life, and my adrenal and my cortisol levels are going, firing. Or I could have chronic fatigue because I got exposed to mold or mercury or something. So there's different causes.
Correct.
For the
symptom.
For the symptom.
Correct. But in conventional medicine, we just treat the symptom. So, and that's very frustrating to a lot of my colleagues who are MDs and DOs, where they feel like they're just band-aiding everybody. So I'm giving them a Band-Aid. Oh, you've got reflux. Well, here's a PPI. Here's omeprazole, which is not going to fix you, but it's going to treat your symptom so that you feel better.
So let's talk about, I got angry. Like for myself, I got angry when I found out this other side, and the medical training that I had, I got angry because I was like, why didn't I get taught this?
Right.
Why? And I have my theory, but I want to hear your theory. And maybe I kind of believe that it was because of World War II that the curriculum got changed. With Hitler and the pharmaceutical companies kind of came on board and kind of helped change the curriculum. And why in your opinion too, is Why was MD become the standard when what you're saying, why wouldn't we want all healthcare practitioners to learn the cause?
Wouldn't that be a nice word? So most medical schools up until the mid 1900s were naturopathic medical schools. So if you met a doctor who's still practicing right now, who was in school in the 1900s, early 1900s, they know about hydrotherapy, they know about herbs, but they also know about the pharmaceuticals. They also know about surgery. Your old time docs, that's what they were. They got my training at medical school. So they were trained on pharmaceuticals. They were trained on nutrient and health and diet and get out in the fresh air and get some sunshine, okay? It was in...
And they didn't have all the tests, so
right,
they were
they didn't
more,
have
they leaned
so
on
they
their
had
instincts.
to go with their, the doc who kind of revitalized naturopathic medicine, or at least gave birth to Bastyr, where the medical school that I went to. It's named after one of these old time docs called John Bastyr.
Okay.
And in the 1980s, he started realizing that the old ways of medicine that were still valid were dying off. And that he was seeing all these other new docs coming in that only knew pharmaceuticals. Well, pharmaceuticals are great in certain conditions and in certain scenarios, but they fail almost every single time when you're talking chronic care. And he started training or teaching other doctors this kind of medicine. And he had a couple of sayings. One is that your intake gives you 90% of your diagnosis. So you should know what's going on with the patient after you do your intake and your physical exam. You testing to support your diagnosis. You should know what's going on with the patient after talking with them, because they're going to tell you what's wrong if you actually give them a chance to do so. So my first intake is between 60 to 90 minutes.
Wow. I mean, because the average is 13, 14 minutes, right? When you're seeing
60 to 90. So when I'm seeing a patient for, say, hormones, I'm asking them about their fatigue, I'm asking about their digestion, I'm asking about their sleep, I'm talking to them about their menstrual history, I'm talking about everything from top to bottom.
That is why they said you're so thorough.
Yes, exactly. My 90-minute consults are usually the ones that are more chronic, or they're chronically ill. They usually are my infectious patients because they're going to have a huger history and a lot more problems going on than, say, my patient they're coming to see me for a sore throat. That can be a lot of different things, not just a cold or flu or strep. So you're talking about a lot of different things, not just what they're coming in for. And so when you get the whole picture of what's going on with that patient, you can start putting together what actually the problem is and narrowing down what system is out of balance, which areas in their lives are out of balance, and where do we need to focus.
Back to lab testing. So when do you rely on the lab testing? If you're saying most of that is, I mean, are you still doing the lab testing or just to verify your gut, or sometimes you save the cost and just go off your gut?
So it depends on my patient, but most of the time I really highly encourage getting the labs to confirm the diagnosis. Because I have to make sure I know what I'm doing, okay? Now, I'm not wrong. I would say I'm wrong maybe 5% of the time. 95% of the time, I knew exactly what was wrong, and the labs confirmed exactly what I was thinking, okay? I've run into a few patients where I was scratching my head, okay, I looked at the most obvious. So in medicine we say we look for horses, okay? Then I start looking at zebras, okay? So if somebody comes back completely normal on lab work, then I know, okay, I know exactly what else is going on then. And I do the other testing to confirm. But most patients are pretty straightforward, and they're usually always kind of what you're thinking. But occasionally I run into those that had me out in left field a couple of times. But I will keep working to figure it out. because I like the detective work. I like trying to figure out what's wrong. And so if I can figure out what's wrong, then I can get that patient up to a point where, oh, now I'm feeling really good. Now I'm feeling like I can actually get out and live my life again.
No, I think that's why Lyme disease, if you like the detective work, I
Yeah,
think that's why
it does
you
fit
like
that
Lyme disease.
I don't like it. It's the bane of my existence, but it does help that detective kind of in me, that trying to piece it together and try and figure it out, because it is so multifaceted, it's so multifunctional, so multi-system, that if you're not looking at the whole thing, you're gonna miss it. And you're gonna miss the piece that actually gets the person better. Because that's the other problem with Lyme, is that it is not an easy diagnosis and it's not an easy treatment. And if you're only looking at it from the immune standpoint, or only looking at it from the toxin standpoint or the bacterial standpoint, you've missed the disease. It's not gonna get better.
So let's talk why it's misdiagnosed, and what people that are listening to this, that maybe they within themselves that their physicians aren't picking up. Why are so many other people, why are so many of your patients going to other physicians and their other physicians are missing it, and then they come to you and you're like, this is what I have. Why is that? Why are they being misdiagnosed?
Well, there's several reasons for that. The first problem is that public health wise, we're told that Lyme does not exist here in Utah. Because we now know that the bird population, especially the finches and the robins, are picking up the ticks and flying them all across the continental United States, up and down into Central America and up into Canada. So when you look at the actual tick population, we've had infected ticks that we've found, just the schools here, the entomology departments that have just done a survey of the ticks to see, well, how much of Lyme do we actually have? Well, they found a huge Lyme pocket up around Heber, the Lehigh Bench for some reason, I have no idea, around Willard Bay and around the reservoir down south. Well, they're all waterfowl refuges. Dropping out the ticks and flying on. So we have a huge problem with a lot of these tick-borne illnesses coming into the state on birds. It's not because you left and got it somewhere and came back here. I have a lot of patients that I diagnose almost every year, at least 10 to 15, that never left the state. They've lived here their entire life. Where did they get it? And they come back CDC positive on testing. The other problem, why it doesn't get reported, well, there's a couple of reasons why it doesn't get reported, but we don't test for it here because we're told it's not here. So from a doctor standpoint, as a GP, you come in with migratory arthralgias. Well, unless I was trained on the East Coast, I'm not going to know what that means. I'm not going to do a Lyme titer. I'm going to say I'm going to send you to a rheumatologist, who will then say, well, you probably have rheumatoid arthritis. It's an autoimmune condition. And you get labeled with that right off the bat. You start on steroids or some type of biologic that then screws up your immune system, and you start getting worse immediately. Infection. You put on something that modulates your immune system or shuts it down, what's the infection going to do?
It's going to
be insane.
Yeah.
And so these patients get worse, they stop their medications and they're going, what's going on? The doc's like, well, you guys keep taking on the meds because the immune system is freaking out because you've got this autoimmune condition. Or you've got an autoimmune condition that I can't diagnose because you come up with funny antibodies every time I test you. Because these infections it's like a nuke going off in your immune system. So your immune system's ability to see the bug and to mount a good immunological defense is gone. So it starts putting out random antibodies that can cross-react with our testing on ANA and antibody panels, and then all of a sudden you've got lupus 1 month, and then we repeat the testing, and nope, you're testing for Sjogren's. Well, that doesn't make any sense, and the doctor starts scratching their head and going, well, what's going on? You've got some type of autoimmune condition, but until it's fully manifests, I don't know what to do for you, and send you on your way. Come back to me when it gets a little bit worse.
That's not helpful, and
No.
it extremely frustrating for
Yes.
the patient.
Or the patient is
And
told
that's
that they
exactly,
need to.
they're wanting, yeah, I mean, here they are trying to take charge, they're going to the
Mhm.
physician's not giving them answers, and,
Or they're told it's all in their head, or they need to go see psych. The number one thing that my patients are told.
oh, that's sad.
And then as a last ditch effort, either one of my patients give them my number, or they get on a forum and starts talking and they get my name, or they get into functional medicine doc. That's when they end up in a functional medicine office, or my office. And we listen to their story and go, yeah, I know exactly what you're dealing with. Because I hear this story all time and time again.
Well, and there's lots of false positives too.
No.
Okay, cause I
Okay,
have
so
been told.
let's talk about the testing. So, and this is where, I think a lot of miseducation happens, because a lot of times we don't understand, as doctors, we're not really trained on the testing.
Okay,
And, you're not trained on how to read the testing until you get into residency, when you start doing testing, and then your head doc is telling you how to interpret the tests.
okay,
Well, my background is in medical. I'm a medical laboratory scientist. So I was trained as a med tech before I became a doctor. So I knew these tests in and out. I know exactly what they're testing for and what they can't be tested for and whatnot. Now, when you're talking a standard Lyme Western blot, well, let's start with ELISA, because when you're talking CD or Lyme's disease, and in the write-up for the disease that this is a clinical based diagnosis with laboratory support when possible, because nearly 60% are seronegative. They will never test positive on a Lyme Western blot, and they're confirmed by culture spirochete positive. So we know they have the disease, but they never come up positive on testing. So that's
but
one thing they need to do.
Western blot is
Now,
is
is
the
a gold
standard,
standard.
is
Now-
the gold standard.
Now, they talk about two-step testing, ELISA to Western blot. Now, the ELISA and Western blot was set up for research criteria to be enrolled into a research study involving Lyme's disease. So you had to be ELISA positive and positive on a Lyme Western blot to be able to be eligible for enrollment in a study to test Lyme's disease. Wanting to get enrolled in a study to further testing or further treatment for Lyme's disease, you have to be positive on the two-step tier testing for.
Are people covered with insurance on that?
Yes.
They are covered.
Now-
If they have positive, but if they're not positive on both, are they covered by insurance?
Even if they're not, they're still covered by
They are,
insurance.
okay.
Yeah. Now, unless you're talking IV antibiotics, and then that gets to be a little bit more dicey. But and if you wanna go back into the politics with Lyme and how it kinda got set up the way that it did, right now, there's a lot of controversy on how things happened, what happened with Dr. Steer and a lot of the higher ups in the CDC and the Infectious Disease Society at the time, when the Lyme Western blot was being put forward as the standard test.
Mm.
He developed the ELISA and the Lyme Western blot. He was research back in the 80s saying that in the infectious disease archives that was talking about how we're missing too many patients that are positive with Lyme Western blots. This is not an accurate test. The lymphocytic activation tests were more accurate. Looking at the immune system was more accurate to determine if a patient actually had Lyme versus the Lyme Western blot.
Okay.
Well, Steer went to, during the time that these studies were being brought before the Infectious Disease Society, he took it to the insurance company and said, well, I'm the head of the CDC now. I'm actually going to make these the standard of testing for Lyme's disease. So this is the criteria that will be met for diagnosing Lyme. So unless you had a positive ELISA and a two-step Lyme Western blot, you didn't have to cover Lyme on the insurance standpoint. Now, there is some litigation that is starting around this, and It'll be interesting on how that moves forward and goes before. We have a lot more, there are thousands of studies that have actually shown the atrocities of the Lyme Western blot. The ELISA is only accurate for the first 3 months of infection. So after a tick bite, you might get an ELISA to go positive, okay?
But after
So
that,
after 3 months,
wow.
the antibodies have converted, and so you're not gonna get those heterophile antibodies coming up against the Lyme to test positive. So the ELISA is not accurate after 3 months after the infection or the bite. The second, the Lyme Western blot, you have, and this is where a lot of conventional docs don't quite understand immunology, which they went through the same immunology class that I did, so I'm not quite sure exactly where the disconnect is. But again, you're thinking acutely. So when an acute infection hits, your IgM antibodies come up, and then your IgGs take over.
Yep.
And then the IgGs will persist in low amounts, so you can get a few IgGs coming up every so often if something happens.
Mm-hmm.
Well, with a chronic infection is going to reactivate an IgM response. It's not because you get reinfected with the bug. It's because your immune system is, again, seeing it for the first time again and reactivates that entire chain. And so your IgMs will boost again, and guess who else kind of pops up is your IgGs, and they spike. And so all of a sudden, if you can catch them on a reactivation immediately, you'll get an IgM and an IgG positive CDC Western blots, okay?
Okay.
But if they're long-standing and they haven't had an immune response in a long time, you think you're gonna get anything on a Lyme Western blot? No, because they're not making any antibodies because they can't have an immune response because their immune response is almost dead. So unless you stimulate that, you're not gonna get the response. So when you're talking an immune-based testing, you have to have an immune system present to be able to get the positive tests. Now, the other problem is cross-reactivity. Now, a lot of the bands on IgG and IgM will cross-react with certain other spirochetes and viruses. So if I say a patient comes back with a 41 on IgG or IgM, well, that's a common cross-reacting band to Epstein-Barr and cytomegalovirus, which is about 60% of the population. If they have a reactivated Epstein-Barr infection, they're gonna come up with a 41. That doesn't mean that they have Lyme. That just means that I see that, I might say, oh, you might have a viral infection. Does that fit your clinical history? Could be. Let's have Epstein-Barr and cytomegalovirus, okay? But there's other testing now that we can do to kind of look to see if I need to go down the rabbit hole of Lyme. So CD57 cell count. There's a lot of immunological markers that I can look at to see if your immune system is decimated. There are PCR testing that we can do, looking for the actual DNA of the bug. But again, I want to try and elicit an immune response so that you're killing the bug, so that we can pick up the DNA.
Because the bug can go dormant, right? My understanding
Lyme,
is the
you
bug
can get
go dormant.
you can get it into remission. So if your immune system is strong enough, so say you get bit by an infected tick, okay? You get a bite from a tick, it only needs to be attached for 4 hours to transmit the disease,
Wow.
okay? So it transmits the disease to you. You have a flu-like symptom. Most patients, oh, I got the flu.
Yeah, yeah.
I have some muscle aches, I have some joint pain, I might have some skin crawls, I might have some cognitive dysfunction, and then within a week it's gone. You thought you had the flu. Well, your immune system was able to get on top of it and put it into a little box, just like any latent infection.
Right.
Well, that can lay dormant or in remission. I like to put it as that because it's not necessarily dormant. It's still active, still replicating, but your immune system is containing it.
Not the same as so when people say reverse the disease, can you
Disease, you're putting it in remission. So I put it more in the kind of cancer aspect because you're not really getting the disease out of you, okay? Once it gets chronic, So chronic means that it has gotten into the cartilage of your joints, it's gotten into your heart tissue, it's gotten into your nervous system. You do not want your immune system, for very good reason, to go in there and start killing infected cells. We have barriers to keep that from happening, right?
Mm-hmm.
And so when it gets into those systems, which it has a predilection to do, and it likes to do, you're not getting rid of it. So now it's normal flora for you, okay? So you're not gonna get rid of it. It's now your nice parasite,
Yeah.
okay?
Yeah.
So just like any other chronic disease, you have to manage it. And you manage it by keeping your surveillance program, or your mom, nice and healthy. So if you can keep your immune system and your natural killer cells nice and happy, they can police the Lyme really well and keep it from going out of control. Well, if you can keep it from going out of control, you're in full remission. It's not doing damage. It might be causing a few minor problems, but nothing that your body can't handle and go back to normal function, okay? So it handles whatever little, it's just like having a teenager in the house. Every so often he comes in, makes a mess, and mom cleans it up, okay?
I think that is so important for people to know, because you know, there's such a dread with you know, you got Lyme disease, you're gonna have the rest of your life, you're gonna be sick, and you won't, you know, you're never gonna get better.
It's just
That's
like
a lot
saying,
of them
yeah,
feel, a
that's
lot
a
of
lot
them
of
feel
things.
that way.
And I mean, I look at it as, it's just something that you need to learn how to manage. It's like having
So
diabetes.
good.
You have diabetes. You have hypothyroidism. I can't fix those. You're not gonna get rid of them, but we can manage it to the point where you're either not having to take meds, or that you're living a healthy life without having to be bothered by it.
So let's talk about it, because earlier you'd kind of told me that you were kind of now kind of a special, you know, your specialty is kind of endocrinology in a way.
Mm-hmm.
Hashimoto's is a really, really big thing as well, and so many people are thinking, okay, once they have Hashimoto's, they can reverse their Hashimoto's, or, you know, or not develop into hypo or hyperthyroidism.
You can
let's make it into
control the Hashimoto's. It's not you can't reverse it. So, and that's where, kind of coming from a allopath standpoint, that's their goal. They want to reverse it, or that we take out your thyroid, okay? And we just put you on thyroid medication, because you're gonna be hypothyroid. That's that kind of thinking. You're never, once you've got Hashimoto's, it means your immune system is attacking your thyroid, okay, for whatever reason. Be it, oh, I eat too much gluten and now it's developed an antibody to the TPO antibody molecule. Or I've got Epstein-Barr that's gotten into my thyroid and it's popping it, and now I've got thyroglobulin antibodies, okay? Whatever the problem is, and those are just two examples of how it can arise, there's multiple other examples. Once you figure out what the problem is, if you remove that cause, yes, the Hashi will get better and you get better control of it. You can get those antibody titers to drop like a rock and your thyroid levels to normalize to the point where you may not even need thyroid medication, okay? But you have put it in to have Hashimoto's. Eventually, that lid can come off and your immune system can go out of control again. That's the problem with an autoimmune condition, is that you're managing it your entire life to control it. It isn't, because if you start going off the rails and start eating gluten again, you're gonna flare the Hashimoto's again. Or if your immune system drops and the Epstein-Barr flares, it's gonna start flaring again. So you have to manage it. It's a lifelong management. Just like with cancer I look at it's the same thing. And I think a lot more oncologists are starting to understand this, and it's embraced alternative medicine. A lot of oncologists, they either embrace it or still kind of shy away from it. But some of my rotations through the Cancer Treatment Centers of America was kind of very interesting in that you're looking at cancer as something that you're putting into remission. Everybody has cancer. At every state, at every second, we are making a cancer cell.
Yeah.
Now, our immune system, and there are certain safeguards that just kill the cell. That's keeping it contained and in remission, okay? Well, when those safeguards start going awry because we're not eating healthy, we have a very toxic environment, we're horribly stressed out, our immune system is no longer functioning for whatever reason, those mechanisms cannot contain it anymore and it flares out of control. Well, if you put those control mechanisms back and you start to a point where now your body can control it, you put yourself into a remission state. So again, with every single chronic state, you're trying to get yourself back to a homeostasis where your body can now control what it's having to deal with. But you're always going to have to deal with it. If your genetics are more to an inflammatory condition, some people have more predication to osteoarthritis in their family history. Well, if they can control the damage that is done to their joints, because they minimize the amount of trauma that is done to their joints, they keep their inflammation low because of their diet and things, they're not going to have as severe of osteoarthritis as their parents, so to speak.
Knowing this about your body, using the nutrigenomics, the lifestyle, that is all about how you're
taking
have
control.
to take charge. Yeah, taking control. How are you taking charge? Because you can have a physician, but you're the one who has to understand your diet. You're the one who has to understand your lifestyle. You're the one who has to regulate your sleep and your relaxation and how no one else can do that for you. So in a way, we're all responsible of assimilating this knowledge into our life.
Yeah. Well, I like to tell my patients that, look, all I'm doing is giving you more education about you. You're the one that has to go home and do what I tell you to do. So either you don't do it or you do it. It's not on me to make you do what I ask you to do. I'm not there to tell you to take the pill. If you're not taking the pill, then you need to tell me why and what's going on. Do you just have problems taking pills more than once a day? I'm one of those. I sometimes forget my evening dose of nutrients. I have a hard time taking pills in the afternoon. In the evening, I just go to bed because I'm too tired. Okay, could you take it a little earlier, like with dinner? Oh, I could do that. So my job is to try and figure out how to make it work for you if you let me know.
I thought that was the job. Hold on, I'm
Yes.
going to interrupt you there.
Mhm.
So tell me that job versus the health coach's role and how you integrate her.
So my health coach, my MA, who is fabulous, her role is to try and help give the patient, if they need that, this is the other part of that, is that do you need more accountable? So they may only see me every 3 to 6 months. So if they need somebody and every time they see me, they're like, oh, I've been such a bad patient. I haven't been taking my meds and I haven't been taking my supplements and now I know my hemoglobin A1C is going to be higher and all these other things. Then it's like, well, because you're only seeing me every six months, maybe we need to have you set up some time with the health coach for her to hold you accountable for things where she calls and talks to you once a week or once a month and asks you about how are things going? What goals have you made? Have you been able to implement any of those? So that's where the health coach kind of comes in to try and help hold people accountable if need be, and if they need to.
Because that was that piece, yes. And I was like, okay, and then you had a second thing.
And then also, the health coach, Carly is also instrumental in helping patients kind of implement the diet. So I may talk to them about what diet I might suggest for them based on what's kind of going on with their nutrigenomics or what healthcare needs they need. And then I kind of hand it off to her to help them implement it. Because just giving a handout, a lot of patients, I have no idea what to do with this. You want me to eat 60% fats and 30% protein and how many carbs? Well, I don't know how to do that. So Carly is great at helping them kind of, these are the kind of foods that we're talking about. These are the kind of meal plans that we're talking about. Demystifying what macros are, protein, carb, and fat are. And trying to figure out how that they can start tracking that so that they can, now I understand my ratios. So she comes in more on the nutritional side of things to try and help them implement. Where I'm just kind of, this is where I want you to go, and see if you can get there, okay? And then hand it off to her.
And you don't have the
Yeah,
time.
I don't have the time to
for
educate.
that.
So that's what's great about her, is that she can start educating.
Awesome.
Now, the second part to that is that as doctors, and a lot of doctors hate it when I say this, is that we're experimenting when I give you a treatment protocol. I don't know how you're going to react to something.
Yeah.
I have a lot of clinical data backing up the med I'm giving you, the nutraceutical I'm giving you, or the treatment protocol I'm giving you, but I have no idea how you're going to handle it. And so we're going to do an experiment. We're going to give you this treatment protocol and see how you respond.
Now, that is true when you hear people
Mhm.
say customized, personalized care.
Yeah.
That is true personalized, customized
Yeah.
care. And I don't mean to offend anyone here
No.
either. I've met with a variety of different physicians, but I think that sometimes we just naturally want to go, I went to school 8 years and I keep studying and I keep, I'm constantly studying, and my ego, and this is what it says. This is
Yes.
what, this is what all that knowledge
The
that I
research was saying.
learned. This is all, I am right because, and I think our egos get in the way.
Mhm.
Especially, if you went to all that training, I think the ego gets in the way instead of listening.
Well, I think that 8 years of med school and residency gives me a little bit better knowledge to decipher all of the information that is coming at you from the research side, to distill down to what is the most salient points that may help you as a patient. In protocols, I am constantly called up, and Carly's constantly fielding calls of, well, what's her protocol for treating Lyme? I don't have one. There is none. What's her protocol for treating Hashi? Again, I don't have one. There is no protocol. When I'm seeing a patient for the first time, I'm building your treatment for you at the time. And many of my patients don't realize that no, I'm picking and choosing things to try and fix. So in med school, we used to joke of, God, I wish I was just a medical at the University of Washington, and I just had to go through rounds, and they tell me, well, what PPIs are you going to use for this reflux, and I can just rattle off a few and the dosing and go move on. Naturopathic school, resident comes in and, okay, this patient is having reflux. Well, what kind of reflux? Different types of reflux?
I didn't.
You could get 5 different treatment protocols to treat reflux. Oh, well, the patient has reflux. Well, what other symptoms are associated with that? Are they having fatigue? Is the reflux going all the way up into their throat, or is it just staying into their stomach? Are they getting nausea with it? Are they having maybe some bile upload? Is it making their digestion sluggish? Are they breaking down their food? Are they not? I mean, 9 times out of 10, reflux is caused by low stomach acid. Why would I give a PPI that's blocking stomach acid to a patient who has low stomach acid? I wouldn't. Not from that standpoint, at least.
Well, that's so. In fact, a lot of people are. I have read. They take betaine hydrochloric acid. See if you're responding. If you feel upset, then that's probably not the dose for you. And betaine hydrochloric acid and now even allopathic medicine is gaining more attention, and we're paying more attention to the gut health and the microbiome that naturopathic physicians have paid attention to for years.
Gut health since before I was in med school. That they've been talking about IBS, and they've been talking about leaky gut syndrome and small intestinal bowel overgrowth. Now, and we even had studies backing it up. Now we have mountains of data backing it up. And now allopaths are starting to look at it.
That's
because now we have mountains of data. So it's funny in medicine that when you're talking something that is it's simply conceived, you can't quite wrap your head around that because it's too simple. And so until you have mountains of data and research backing that up, then it's valid. Well, how about
We're missing a lot in medicine,
Yeah.
then. We really,
Yeah, we are.
as a overall, we're missing, if we have that mentality, which we do, and I mean, I worked back east at Yale, a prestigious hospital, and it was all academia, and they wanted, and they all wanted the study behind their name, and in my opinion, I think, and now we even have heard, drugs are taking 20 years to come to market and $20 million because they have to go through all the pharmaceutical studies, when here we know simplistically this is what this chemical or this compound or substance is doing, but then can help with, but then we're limited, and then physicians go, it's not FDA, I can't use it, or they, or the supplement, I don't know anything about that, and they're shutting down what people
And
are
that's the other
saying.
problem, is that it is FDA approved. It is FDA approved. FDA approved. They just don't take the time to research it. That, like, I had one patient the other day that she started having myoclonic jerking, and her nervous system was going completely haywire. They take her up to primaries and they say, she's got to be off all her supplements. She's getting overdosed on the supplements. She was taking a vitamin D, a B complex, a multivitamin, and like some fish oil.
Oh, so not really.
And her levels were fine,
Wow.
but she was getting overdosed by the supplements. Probably something else, but it's good to try. But she was also on 3 pharmaceutical drugs that they didn't take her off of. I just found it interesting that they jumped right there, and it's like, but what about the other 3 meds that she's on? Why wouldn't you take her off of those too? Because one is known to cause myoclonic jerky.
Wow.
So, I'm not quite sure what to say about that, other than your biases are coming out. And you really don't know what you're talking about when you're talking supplements. But that's the other problem on the allopathic side. They're never trained. I mean, nutraceutical training. I had 2 friends that were in med school when I was in med school, and we'd constantly talk about what we were learning. And, oh, did you learn about this? And no, we're both in cardiology. We're not learning the same thing. It's kind of sad. But their nutrition, I had 7 nutrition courses. They had 2 lectures. What makes our bodies function on a daily basis, what makes our biochemistry and our physiology function on a daily basis is our nutrition. They get so surprising that they're going to be a little hesitant to keep you on a supplement, because they have no idea what you're talking about when you start talking about fish oil, other than what it's related to cardiovascular disease, or what we know about in the studies now. Because it's starting to be more and more talked about. Or a patient brings them a research study and hands it to them and says, oh, I did not know about this, I'll have to look at this. They'll either look at it or put it on their
Desk and don't
time.
look at it.
And the piling research studies that are in our inbox, yeah.
So how do we change this? How do we change this?
Is start changing how we train doctors. But as I've been listening to a lot of my colleagues who are MDs and DOs, they're getting so frustrated by doctors coming out of medical school because they're not even trained on how to diagnose. They're trained on protocol medicine only. And so you have A, you give B. You have C, you give D.
Mm-hmm.
So they're trained on protocols. They follow protocol. They're not taught on how to actually adequately diagnose. They're not trained to think outside of the box. We're not putting out doctors that can diagnose these chronic illnesses very well because we're not training the doctors.
Well, and
So
doctors
until we
aren't
start
getting
training
paid anymore
No,
either.
No, they're
not
getting
even
paid less. And so there's no incentive for them to even learn, on top of the fact that the insurance companies are dictating what we can do. They're the ones that started this whole protocol in the first place. Well, are you following protocol? What protocol? There is no protocol for treating a chronic disease. Hitting those bullet points that insurance wants to make sure that if my patient wants to submit for billing, they'll get it.
So you're
Okay.
unique that way, cause you don't,
Mhm.
you don't bill for insurance, you're a cash pay practice. Most physicians here in the state of Utah that are naturopathic physicians
Mhm.
you guys are kind of forced to be cash pay, is my understanding.
Yeah. Well, the state legislature put in our CRE, basically, in our licensing, that insurance companies do not have to pay for naturopathic services, so alternative services. So, and that was lobbied by IHC.
Of course,
IHC did
yeah.
not want to pay for naturopaths. There are a lot of insurance plans that will pay for naturopathic, because we're GPs, we're considered
Yeah,
GP.
yeah.
So as long as we're doing your allopathic care along with our naturopathic care, as long as we're treating you as a doctor, that's still reimbursable by a lot of insurance companies. So some that consider out-of-network benefits, we fall under that category, except for IHC.
Let's talk about that, because a lot of functional medicine practitioners are, they've been trained maybe allopathic, and then they're trying to, they've been converting or trying to convert over to functional medicine, and they're
Yeah.
trying to establish a cash pay, practice, and they're failing, right? They're failing because they can't get their people to pay, and here you are, you having a successful, practice that's cash pay. And there's a lot of advantages, because you're not dictated by what the insurance is doing, like we've discussed. You can practice in,
I still am to a degree, like getting meds done or getting certain testing done. I have to still jump through not pharmaceutical, but insurance hoops to be able to get things paid for. But, or disability, I have to jump through certain hoops to get patients. We're still going to be tied by insurance, whether or not we like it or not. It's just now, it took me over 15 years to get to where I'm at right now. It wasn't overnight that I had a busy functional medicine practice and I'm doing just fine. However, most docs, I think, they either go too quickly to cash pay, or they're trying to do the whole 1 foot into one and 1 foot in the other.
In another world, the both of them.
The problem, and this is what I saw when I worked with a neurologist for about 10 years, and our biggest problem was if she did anything alternative and put it in her chart, and we got audited, we had to pay that back. Because she's contracted as a neurologist, allopathic wise. So if she steps out of that box, you can't charge for that care. Diet, they could come back and say, well, you talked about diet. That's not protocol for this disease. Okay. We kind of need to for a patient who has Parkinson's and they're damaging their brain. It helps
Because of the foods they're
to
eating.
have some healthy fats would be helpful for their brain and to take away a lot of the grains that are inflaming it. But for an insurance company, if you're breaking that protocol, they don't have to pay for it. So if you chart anything in your chart saying that you did something alternative, or what they think is alternative medicine, they don't have to pay for that visit. And so a lot of docs get very frustrated because when they start doing functional medicine and they're trying to code it like they usually code things, and then they get chart audited, they're going to get dinged. They're trying to do is be helpful for their patient, and yet the insurance company is going to come back and stab them in the back. Because you're taking too long with your patients. So if you're billing too many higher codes, because you're spending 30 minutes with the patient to try and talk about everything that's going on, because they're complicated patients, if you didn't hit all those bullet marks, what they're looking for, and you charted that you actually talked to them about diet and lifestyle, and put too much information about supplements or something else, they don't have to pay for that visit.
I mean, the physical body, the nutrition, even sometimes the emotion and meaning in the lifestyle, that's the base of what creates
health.
Creates health. And there's so much well, there's a lot of information out there with diet. There's a lot of, and I even think social connections and emotional support, there's a lot of people that are missing that in today's society.
Right.
Where, you know, how many people do you have come to you and say that they're depressed? Assume.
But would that not be because they're not being heard and they feel sick? I mean, of course, that's gonna be a little bit of depression, but that's not because they have depression, it's because their physical symptoms are starting to create depression. But what do? Oh, let's just put you on Prozac. Well, because it's not the actual problem.
Yeah.
I felt tired all the time, and I'm in pain, and I'm having cyclic bowels and everything else. I'd be depressed too. That
Yeah.
sucks.
Yeah. That you're spending, right, with, you would have to limit how many patients that you actually would take or can see. Right?
Mm-hmm.
And because it really sounds like you're really trying to take care, and that your joy is really getting or reversed or remission, or that that they feel better after seeing you.
Mm-hmm.
I can't, I don't know if, unfortunately, I just don't know if they're going to a regular physician, if they even have time to care, because it's 15 minutes in and out.
Mm-hmm.
So that would limit the number of patients that you could see. How do we scale this? How do we get the information and to
Well, your
to
other
people?
problem when you're talking insurance is that insurance doesn't reimburse for your time. They reimburse. You are a practice that is more, I'm not doing procedures, I'm trying to fix a problem that a patient might have, and talk to them and encourage them to change their diet and lifestyle, and actually do preventative care versus, oh, cancer screening is preventative care. No, preventative care is talking to a patient about their diet, their lifestyle, and their moods and everything else. Fixing what's going on in their life so that they don't develop diabetes, they don't develop chronic cardiovascular disease, they don't develop dementia because they went menopausal too early. All of those things can cause, that's preventative medicine. We don't pay for that in this country. So until we even change the model of care that we have, where we actually start reimbursing doctors for outcomes, and not outcomes from procedures, but outcomes from, are your patients getting better? Are your patients improving? Are their preventative health measures going down? They're actually getting better, and they actually feel better, and their well-being is going better, and we're creating healthier citizens. That is the true role of a doctor. Our role as doctors and physicians are to be able to make our community better and more healthy, so that we're not treating chronic disease down the pipe. We start educating our kids how to eat, and and that we do need to exercise. We need to move our bodies. That's the position. But we don't reimburse for that. We're doing a surgery. And keep their office doors open, they have to do procedures. If they don't do procedures, they're going to die. They just can't.
They can't see business, it's not business practice.
They can't pay their staff, they can't pay their overhead, they can't pay their malpractice, they can't pay their student loans back. I mean, our student loans are astronomical when you're talking those. Most doctors, when people think of doctors, you think of they're at the higher part of the pay scale. Unless I'm doing procedures, I'm not at the high end of the pay scale. Most family docs are down here with regular run-of-the-mill folks, but our debt is like up here.
Yeah.
And so when you're starting to talk about this national healthcare crisis, we've created this model that can't sustain itself because we're not doing medicine anymore. We're doing procedures. And say, oh, well, you need to have a nerve block, or you need to have oh, you have appendicitis, we need to take that out.
Yeah.
Or you're having incontinence, well, let's just, you're done having babies, so let's give you a hysterectomy and a bladder lift. So in 3 years, we'll do another bladder lift when it starts to fall out in your vagina. That isn't good care. How about we actually look at hormones and start looking at the viscera and looking at how can we increase the tone and the strength so we don't have to do surgery to get a body part.
Well, and a lot of hormones aren't talked about.
No,
Like
we're not talking about hormones.
Hormones aren't talked about in medical school really at all.
Oh, no. And even in naturopathic medical school, when we're talking bioidenticals, I got one day talking about bioidenticals. And then the biggest question of all of us that were in the class is, and how do we prescribe these?
Wow.
I have no idea. Yeah, okay. So I know I do estradiol and estriol, but I have no idea how to prescribe it because nobody's giving me any information. My prescribe. And that was, again, experimenting on my patients. And now I kind of understand the ins and outs and nuances, and I can kind of give that to other physicians, but because it is such a customizable approach, I at the same place. I don't treat, not everybody's going to get biased with progesterone, or not everybody's going to get the same dosing of progesterone. It's going to be based on the patient and what their labs are and what their symptoms are.
Yeah.
And that takes nuance. I mean, right now we have 2 new practitioners that are trying to get their feet wet with bioidenticals. And the way that we talk to them is that, you know what, you have a hard case that you're not sure where to start them, you come talk to me or to Christina and you ask us questions. We'll give you some guidance. That's how they're learning. But if you're by yourself in a clinic, you have nobody to call and ask. And that's the other problem with healthcare, is that we need to have more opportunities for newbies, people fresh out of school, people that are just trying to learn this. Have somebody make some connections and start calling up the functional med docs in your area, call up the docs that are doing bioidentical hormones, call up the docs that are really good at dealing with chronic care, and start asking them questions. Making those networks where you feel comfortable enough to talk to them. Because most of us are very open. We'll talk your ear off for hours. Give us the moment. It's just getting us talking.
Yeah.
Yes, we're busy.
Well, you want to share
come
your
and shadow
knowledge.
us.
You want to. I mean, the
Yeah,
reason you're in
because we need more doctors to know how to do this.
Yeah.
I need more doctors to do this because I can't see everybody. Now, I make a decent living. I could pay a lot. I could charge a lot more than I do. And I have a lot of practitioners that tell me that I undercharge, and I've undercharged for a decade. I did recently raise my prices, and I feel horrible about it, but it's kind of like, I don't want, my philosophy of medicine is more of, I'm not here to break your bank, I'm here to get you better. Mm-hmm. And half of that stress is also financial. And I can't justify charging you an arm and a leg to get you better. On top of the fact that the supplements are expensive.
Right.
Well, I'm gonna have you on a couple of supplements. I'd rather put your money there than towards my practice. I'm making enough to make all my bills and everything else. I don't need anything more. That's my philosophy.
That's
so
beautiful. That's a beautiful philosophy.
That's a hard thing when I'm talking to other practitioners, because I don't have a family, I'm single. I do have a significant other, but we don't need a lot. And so when you're talking where you think as a practitioner, that's where you have to sit down and make your own decisions about that. Mm-hmm. And that is a hard place to be, because especially as a business owner, you have to make sure that you're making enough to meet all your bills and medical malpractice and everything else, on top of giving a good standard of care that you're comfortable with at a price that you're comfortable about prescribing or charging, I should say.
Yeah, no. No, and I know a lot of practitioners who actually really are struggling with that on the functional
Mm-hmm.
medicine side.
And when I started, my prices were really low. And it allowed me, but now I was in a unique position where I was working a second job, to finance. But it allowed me to build my practice and get the word of mouth out. My entire practice is word of mouth. There is no advertising. I don't do any advertising. I do nothing. It is all word of mouth.
And you have
So
a
it's
full
my
practice
patients,
now,
and I have a
right?
full practice. And I got to a full practice probably about six years. But building on itself took time. And by the time that it started getting bigger, I started raising prices. Okay? So you start low, and that's hard when you're first starting out, is what is the minimum that you have to make? And then that's what sets your self-pay price. Then when you get better and more confident and you know what you're doing, raise it. Because more people have confidence in you. And eventually, you can raise it higher.
Well,
and higher.
I know a lot of people will add
Yeah.
the IV infusions,
Mhm.
right? They'll add the
Yeah.
nutraceutical infusions.
And again,
because
I
it's,
don't charge very much for those. And I have a lot of docs that they go, you need to raise your prices. It's like, why? To do a nutraceutical IV. They cost this amount, and then I just do an infusion charge.
Mhm.
And so when you're talking, well, you should be doubling that. And it's like, no, I don't. I don't need to do that. I'm still making my bottom lines. I'm still being able to keep my inventory up, and I'm paying for the infusion. That's fine.
Yeah.
Doesn't necessarily need to be what you charge, and that's okay. A little insane to charge a patient $200 for
Well,
an IV.
I mean, it depends. I mean, some people are
I mean,
trying
let's-
to build their
I know.
practices and they're wanting,
And they do, and that's one
a
way-
chain of practices.
And that is
maybe.
one way to kind of bring in revenue, and also the nutraceuticals.
Well, it's a
that's
procedure,
another-
like you said.
yeah,
It all comes
they're-
down to procedures.
It's procedures, and procedures do make a lot of money. I mean, I had this conversation with a couple of other naturopaths we had this conversation because we had a couple of newbies coming in and they were trying to build their practice, and how do we generate more revenue? Years out of, because barely anybody knows what a naturopath is here. We don't have a lot of them, and we have maybe now 35 or 40 in the state.
Mm-hmm.
So it's not like we're huge. We're not taking a huge chunk of the pie there, but not the way that you build a practice. Well, start offering IVs, start offering trigger point injections, start doing procedures, because again, that makes more money.
Yeah.
Do ozone, it makes more money. It's a good money generator. So yeah, that is one way to do it. For me, that wasn't the route that I went, nor was the nutraceuticals. I didn't carry a huge store and inventory. I just have it online, run by a supplement wholesaler. Most of my patients get my discount. So I don't even take my full discount on the markup on that. So I don't see it as, yes, it could be a revenue site for me, but it's a mild revenue site, but it's not a huge one.
Mm-hmm.
But I look at it as, again, I'm passing those savings on to my patient to lower their stress level. So and that is more of my philosophy of care.
Yeah.
And my philosophy doesn't work for everybody, just like I'm not everybody's doctor, of kind of going on that practice of think locally, and act globally. If I'm not acting to further health for my community, then what's the point of being a doctor and a physician? It goes back to that whole community at large. I see a lot of patients for pro bono. I don't charge them. And I have a lot of patients that I do sliding scale on because I know that they're strapped for cash.
Mm-hmm.
Or they've gone to other colleagues of mine for Lyme and they lost their house because they went second mortgage trying to pay for treatment. They have nothing. So when you're talking about, I get a lot of patients that are almost financially destitute at that point. I can't reasonably and ethically charge them.
Oh,
Yeah.
you have a
And that's how
a
you
heart.
keep your
You
soul
have-
when you're
yeah.
talking medicine. And most docs start to lose that as they get more and more because insurance kills your soul. If you worked at Yale,
Right,
you go
right.
work at a You go work at a hospital, it will suck your soul dry. And most doctors, when they get out of school and I'm going to help patients, I'm going to get them better, you start working for a conglomerate and it sucks your soul dry. And you're like, I hate this. I hate what I'm doing. I thought I was going to make a difference. I'm not doing any of that.
And I would.
And that is really hard as a practitioner.
Yeah, no. I don't know if I've not come across a practitioner that's not felt that at some stage, right? I don't think they're there. When I'm saying that, I even mean medical assistants to nurses to NPs to physicians, the whole gamut of healthcare professionals have felt that
at some point
in their career. Yeah.
Yeah.
Definitely.
Because they don't have control over anything that they do. They can't decide for their patient. They know what is best for their patient, yet I have no way of getting it for you. Because your insurance is dictating one thing, the hospital is telling me another, and I can only do what is set in that protocol. And if I talk to you about your diet or anything else, I'm going to get reprimanded.
Yeah.
And so that is a really hard place to be when you're talking to a doctor or any kind of healthcare worker.
Yeah, yeah. Okay, I have one more. I want one little more conversation, just because I just read this recently, and this is just more for my knowledge of what I've came across versus what you've come across. So I came across a study that was comparing the endocrine system with the endocannabinoid system, and how both of them are trying to create the body and maintain the body back into homeostasis, right? The endocrine system is using your hormones, right, and upregulating and downregulating, 150 probably different hormones, where the endocannabinoid system is using, which we don't know that much about, besides that we have these receptors, and we know that a variety of these receptors are upregulating and downregulating the system as a whole. And there's this whole movement of cannabis, everybody's marijuana, or everybody's CBD. And for me, the medical revolution that we're really trying to portray here is, let's understand this endocannabinoid system and what the system does. And I'm so grateful that there's a plan out there. It makes sense that God put a plan out there, right, that we have cannabinoids. But I don't think people, in my perspective, I don't think people understand that there's, broccoli, cacao, there's other cannabinoids, there's other sources, and we've been feeding the cannabinoid.
Cannabinoids.
Yeah.
So every plant, every animal has cannabinoids in them. So when you're talking, what a lot of patients and practitioners don't understand is that you're talking about the communication networks of the body. About the endocrine system, the nervous system, and the immune system. Well, the basis of that, of what we've been trying to understand this for decades, okay? We still don't understand half of how the brain works, or how the immune system communicates to the endocrine system, and then how that whole symphony actually functions as well as it does, okay? We're still trying to understand that. The cannabinoid system inside our bodies is just another piece of that system that helps with the regulation between those systems. So I think what we're going to be finding out is that is how the immune system is talking to the endocrine system. Now the endocrine system is talking to the nervous system, and vice versa. So cannabinoids there's receptors, and then there's certain types of cannabinoids that we have that hit certain types of nerves, and also all of our cells have cannabinoid receptors. Well, isn't it funny that all of our cells also have all of the hormones affect every single cell in our body? Same with every inflammatory molecule, leukotrienes, prostaglandins. Again, we barely scratch the surface of understanding these molecules and how they're communicating and how they're regulating the way that they regulate. Started to understand NF-kappa B, regulating inflammation. We're starting to understand how the way that we understand these things are actually by giving certain nutrients. So the way that we found out NF-kappa B was actually studying mushrooms and how they regulate inflammation. Then we started learning about NF-kappa B and how it downregulates inflammation. And then we got all of this research on how do we affect NF-kappa B.
And inflammation's
And
huge.
inflammation.
They're talked about all the time
all
right
the time. And so you're talking about, well, just give them a mushroom complex. Have them start adding that into their system. It's an immunomodulator. Same with vitamin D. We started learning about how vitamin D has so many other effects in the body, not just helping with mood.
Yeah.
It helps with making hormones. It helps with regulating our immune system. And it does it through the cannabinoid system. We're starting to uncover this huge lid of things that, oh, there's more layers to unearth.
Well, that is
it's
so...
just it's our understanding. As we start learning more and more about the complex systems, we can now start peeling back more layers and more layers and more layers so that we understand more and more about how the whole system functions so that we can improve it. But the problem is that we legislate things too much to the point where we can't really, and if you really look at hemp and why it got criminalized in the first place was kind of ridiculous, along with marijuana. I mean, it's not necessarily a problem plant to start with. You could also say the same thing with psychedelic mushrooms. There are certain things that we really still don't even understand and still just scratching the surface with research when you're talking about what those plants can do for us and help with our communication with our nervous system and fixing that.
Mm-hmm.
So when you start talking about a patient like an Alzheimer's patient and you start decreasing their inflammation and giving them things that help to stabilize their inflammation, and all of a sudden their brain comes awake, and there's something about that we're still not understanding. Why is the inflammation causing the dysfunction in the nervous system? Why do chronic pain patients start responding to cannabinoids so well when the opiates weren't doing a very good job of it to start with? Or low-dose naltrexone. We still don't even understand how low-dose naltrexone works. But it probably works through the cannabinoid system because it's a very similar molecule. You start looking at it, and you start looking at a lot of these kinds of, again, the whole plant synergistically has a lot of other things more than just the cannabinoids in it.
And I'm going to stress, because we talked about this earlier, there's isolate out there, there's full spectrum products that are out there.
Right.
They're not the same product.
No, they're not the same product.
They're not the same
They're
product.
not the same, they're not gonna have the same effect. They're not gonna have the same types of, just like with, if you're looking at subspecies, say, if we talk about medical grade cannabis. So I prefer saying cannabis versus marijuana because they're different.
Mm-hmm.
They're different. So medical grade cannabis, you have basically two strains that we concentrate. Well, yeah, the three. Indica and sativa are your most common, but and then you have the rhodialis. Indica and sativa, they have different effects on the body, and if you're taking it in an edible versus a tincture form versus a tea form versus smoking, you're going to get different effects. And that's where
onset and duration are going to be different.
Yeah, exactly. And so that's what's confusing the medical field right now, because they're looking at it, well, it should be acting like a drug. So no matter how you administer it, it should be acting the same way. You're talking about a plant. A plant does not work.
I think you guys understand this better.
Plants work in a different way each time the way that you extract it. So when you extract it, you're extracting different concentrations of certain isolates and certain constituents. So when you do an alcoholic extraction, a tincture of an herb, you're getting the alcoholic extractions of the nutrients that can come out in alcohol. When you do a tea, you're going to get the water-soluble constituents out of that. So so when you're doing studies, you have to be very specific on what route of administration you're giving, what type of form you're giving, and you have to standardize it to, a lot of times when we're talking an herb, we try and standardize it to at least one or two constituents. So that you know by GCMS, you're giving the same product every single time.
Yeah.
That's the only way to do a study on them. That's the only way.
Thank you.
However, a lot of us don't do that because we start seeing all these products on the market that we don't know how they were extracted. We don't know, well, cold pressing, some people say, oh, well, cold pressing, I'm gonna get a better extraction method, and it's like, not necessarily. Depends on what constituents you're wanting and what types of effects you're wanting.
Thank you.
That's
for
going to
saying
be
this.
different.
I know.
That's gonna be different.
I've been trying to convey this because I just have so many of my competition out there
Mhm.
that are just saying it's the best, it's the best. And I'm like, no. Like, it depends how it is extracted, right?
Yes.
CO2, ethanol, like you were saying,
Yeah.
it really depends on how it's extracted.
Yeah.
And the other thing that that's
So each
screwing up is
one
dosing.
is going to be different for each condition. So if you say, okay, I've got a tincture here, and I cold pressed it, or CO2 extracted, or whatever you want to say. Well, what are you standardizing it to? That's the first question. What cannabinoid are you standardizing to? And are you using indica or sativa or rhodialis? Are you using just hemp, rhodialis? Or are you using a combo plant? Are you using one that's a 50-50 mix?
Yeah.
I need to know. And half of them can't tell me. Well, we just put a bunch of them in a plant. That does nothing. So that doesn't tell me if I'm going to get more of more of a mood stabilizing effect versus a neurostabilizing effect versus an anti-inflammatory effect versus a anti-nausea effect. All of those are going to be different based on how you extracted it, how you're dosing it, and how you're administrating it.
So I know Israel is
Mhm.
trying to, and they're trying to kind of isolate. They're kind of the taking charge of kind of the cannabis and the studies that have been out
Mhm.
there because we've been so restricted here in the U.S.
Mhm.
And like I said in science earlier, and we've
Mhm.
talked about this, one compound, and we're going to have to isolate that because we're going to have to know what that one compound
Mhm.
does, and then how to synergistically put them together because we as human beings don't know how to do it any other
We
way.
don't know how to do
We
it.
don't know how
No.
to do it any
We
other
don't.
way.
Or we just standardize, okay, for this herb, you're taking it this way, and everybody makes it the same way, like a pharmaceutical
Yeah.
drug.
Yeah.
That's the only other way to standardize it. So, or you make a different process and then study that one and see what it does. That's the only way to pick and choose. The only way that we know that ginger has so many different effects is because we've had mountains of data on dried versus tea versus tincture versus all of this. We have mountains of data on that. We don't have a lot of data on psychedelic mushrooms or cannabis or marijuana. All we know is what we think we were told.
Yeah.
The studies that were done on even marijuana back in the 60s, it's not a gateway drug. I hate it when people say that it's a gateway drug. So, I'd say with cigarettes and alcohol. They're just ways of people trying to numb themselves to treat a condition when they start. It's not necessarily a gateway drug. Now, if you start using it as a child with a developing brain, that becomes more of an issue because you're affecting their cannabinoid system.
Okay.
So their developing brain is being affected by the cannabinoids that you're introducing exogenously. Well, for some of them, it might help with their anxiety disorder or their seizure disorder by calming down that overstimulation that was happening in their brain. So for those patients, that would be an appropriate use of marijuana for those patients, or even medical grade cannabis. But to put it into a child who is normal and not having any problems, and then you introduce, say, marijuana, you're fiddling with their cannabinoid system. And we do not know how that's affecting their endocrine system or their nervous system. We have no clue because we're still understanding the cannabinoid system as it is.
Yeah.
And how that interacts with our thyroid and adrenals and pituitary and pancreas and our nervous system, we have no idea. Or thymic gland that it helps to mature our immune system. I mean, we have no idea how that's affecting it yet. We're still trying to figure that out. And then I mean, adults, because they're grown and they already have their systems and their nervous system all intact, you start them on cannabis and, well, they're not gonna get addicted to it. Most people who start smoking marijuana as an adult, they don't get addiction. They don't, I mean, there's not a, in the literature, most people can smoke just, and then walk away, and 10 years later come back and have another smoke and be just fine. It's not that kind of addictive drug. It helps to mellow them out, and it increases their appetite, and it increases their, there's a lot of effects that they'll get from either eating the brownies, which is a different effect than when they smoke it. And when you talk to people who have done it, they do notice a different effect.
They do.
Okay?
Yeah, they do.
It can cause hallucinations, and the question to that degree is that opening up more of your limbic system to be more creative and to actually start thinking about things. Same with psychedelic mushrooms. The literature and the studies on that is actually very fascinating when you start looking at it, because it helps to improve it takes away some of your inhibitions to try and make a breakthrough. So for most patients, they'll take it, or most people that go down and do the shamanic rituals, they'll say that I was working on a problem or I was dealing with some type of emotional issue, and it gave me the barrier, it took down the barrier that I was dealing with and allowed me to process that problem and move forward. So when you start thinking about how many times would that help a post-traumatic stress patient? How many times would that help somebody who's having chronic panic attacks to kind of try and process what they're dealing with and being able to move forward from that? That would be amazing if we could actually use it here.
Well, there was a study done in Europe it was Rembrandt, and it was on the market, and they pulled it off the market.
Yes.
But it was a cannabis. Are you
Yeah.
familiar with it? They pulled it off the market because it was causing depression and suicidal thoughts.
Yeah.
So we do know to your point.
Yes.
We do know that it's affecting GABA and serotonin. We do we know those
Right.
in the brain.
Neurotransmitters.
We know that it's affecting that. And we don't know exactly how it's affecting it, but we do know that it's affecting it, and that is
in certain types of patients.
Mm-hmm.
And that goes back to, well, looking at your pharmacokinetics and how you process drugs, certain meds don't do well with you. And we give you a serotonin reuptake inhibitor and you go psychotic. Well, we give you marijuana, you're going to do the exact same thing.
Yeah.
So it's understanding the genetics that you have, both on the pharmacological side and the nutrigenomic side. Knowing that whole history of you, then we can customize what drugs we can actually give you and what we can't give you.
So would you say those two tests are now kind of really key tests for? I mean, because they're once in a lifetime tests. It's not like you have to repeat them. But from my perspective, in medicine, moving forward, if you're wanting, to do preventative medicine and taking charge of your health, getting those two tests are kind of, I think, in a way.
I would say that they're helpful tests to have done. I wouldn't say that they're absolutely necessary tests to be done. Because again, anything that and this is my bias as a naturopath, any time that I have to do a test to tell me what to do, that's not for use of that test.
Agreed.
So if I can't figure out, oh, you've got a detox issue, I should be able to know that before I even run that test.
Yeah.
I should know that you're having a problem processing nutrients somehow. I need a nutrigenomics test to tell me how.
Okay.
And why, to build that diet a little bit better for you, because we're missing a piece. Testing. So I don't usually start with that testing right off the bat. I use it more as we're going along the journey. And if we come up against a roadblock or something is happening that you're not responding the way that you should. That I'm missing. So that's when I turn to the genetic testing, because usually that uncovers what's actually going on.
What about just the Genova came out with a test, and it's just looking at like organic acids, and it's looking at your levels of your vitamin levels, and a lot of physicians are not, you know, what, like for me, the story that you were telling earlier about looking at the labs. And why didn't they run a test to see where the vitamin and the mineral levels were? Why didn't they run that test?
Just if you did your intake right. I know.
Right, in their case.
So, and that's the other reason why I get that question a lot also, of patients coming in and say, why didn't my doctor do this? Why didn't they run this test to find out that I have mycoplasma? Or that I am actually hypothyroid and I have Hashi? Or I have severe endometriosis and nobody ran my estrogen and progesterone before you did. That's unfathomable to me, but okay. They don't do it because they're not trained to run the test. Because because they already put you in the box of endometriosis, or you have fatigue. Exercise more and lose weight. Bed in the morning, how am I going to lose weight and exercise? And when I exercise, I get more fatigued.
Yeah.
But they'll tell you still, lose weight and exercise. But to exercise. But they don't even ask those questions because they already put you in the box.
Yeah.
So when you're talking a protocol-driven medicine that does not go beyond your symptom history, that box, because they've been labeled by a couple of doctors as a malingering patient, meaning that trying to have these symptoms, which get a medical record that says that the patient is malingering or it's a psychosomatic disorder. And remember that my colleagues are smart, and that if they knew how to work you up appropriately, they would have asked you more questions to figure out what was wrong. Because no patient wants to be tired. No patient wants to be sick. I've made a patient in my entire career that she being sick.
She like,
okay,
yeah.
Where a patient that's how she got her
Attention,
care and her attention. She did not last long in my practice.
Right.
Okay, so for patients who are motivated into wanting to get better, those are the patients I see. And they're always constantly told that it's in your head, or you're malingering, or it's psychosomatic. Okay, I will agree. It is in your head. You're tired, you're depressed, you're anxious. Who wouldn't be with having to deal with doctors telling you that it's on your nerve pain that is keeping you up at night and making you twitch? Your brain is causing you to do that. They're right. It is in your head. Your nervous system is dysfunctional. But they're wrong on to why it's happening. It's not because you want it to happen.
Well, and I mean, and granted to them, I think the healthcare professionals, and we touch on that, they're equally as frustrated because they don't know what to do either, or they're not educated or what you're, so, I mean, I think that goes both ways, so.
Exactly.
Yeah. Well, thank you for sharing your knowledge and and the plethora of knowledge. I think this is, there's tons of information, little different pieces that people can get out of this. But if there was one takeaway, if there was just one takeaway, right, in creating this new healthcare from kind of scratch, right, if there's one takeaway of how to take charge of somebody's health, what would that be?
Tells you they don't know what's wrong. That's probably, as long as you keep searching, and even as a doctor, if you like they should, and they're taking everything that you told them to do, then you need to go back to square one, reset with the case, and what piece did I miss? Because Fuck, I forgot that. Or this is one of the reasons why we keep going to conferences.
Yeah.
We go to a conference and then all of a sudden a bell goes off in your head and you're like, ah, shit. I know. And then you write it down and you even put the patient's name right there and you're like, I'm so stupid. I know this. I was taught it in med school. I've known this for my entire career, yet for some reason I just I didn't make the connection.
Yeah.
And so as long as we keep trying and keep moving forward, we'll find the answer. You just have to give us time.
Well, that's a good ending. There's always an answer. Keep researching. Don't ever give up. In yourself, don't ever give up. Don't ever give up in finding the right physician for you. And take charge kind of in your diet and your lifestyle and in other areas of your life. Thanks for watching Legends Health, Wellness, and Performance Podcast.
Bye.